It's now an honor to introduce our next speaker. Helen Bevan hails from the UK. I did a little research on Helen's background, and it's humbling to read about hers and considering your own, and the comparison is not flattering, so our CVs, let us say, are different. Helen is the Chief Transformation Officer for NHS Improving Quality. And I'm just going to give you very short highlights of Helen's accomplishments because we want to get to her talk. But among other things, Helen was made a member of the Order of the British Empire in 2001. In 2008, she was named one of the 60 most influential people in the history of the NHS and in the top 10 opinion leaders and opinion makers in the NHS. In 1948, Bevan and colleagues gave the world the NHS, and in 2015, and before and after, people like Helen Bevan are going to change and transform it. So from 1948 to 2015, from the UK to Alberta, please welcome Helen Bevan, who is going to talk about igniting energy for change. Welcome, Helen.
It's wonderful to see so many of you here today at the first Quality Summit, and this is my first ever visit to Alberta, and I hope it'll be the first of many. And my topic for about the next 55 minutes is igniting energy for change. It's really wonderful for me, actually, to be speaking after Peter, because, you know, just listening to that story, I think it really makes us want to do our best and, you know, make sure that every single person that uses our health services and every single family member gets a great experience. So, you know, just thinking about this, you know, and the theme of our Quality Summit here today, igniting energy for change. On our little badges, we were asked to put, you know, what am I ignited by? So I thought maybe I'd talk to you about a time where I felt really ignited, you know, where I felt so energized for change. And it's to do with this. It's to do with something that I helped to set up in England, which is called NHS Change Day. And how NHS Change Day came about was because in 2012, I had a meeting with some trainee doctors, a trainee paediatrician and a trainee GP. And they said, we want to transform the NHS. Like, will you help us do it? So I said, yeah, no, absolutely. So we decided that we would set up an initiative to transform the NHS. Okay, we didn't have any power and we didn't have any money. But what we decided to do was to set up this social movement where, like, for one day, we would get people to take action to make a difference. And we had our first change day in 2013, and then 2014, 2015. And honestly, it's been amazing. And for me, I find it so energizing. And, you know, it's about how do we create a mass movement of people working together in and with the NHS to demonstrate the difference, that if each of us just makes one change or takes one action that will make a difference to the experience and outcome of care, you know, what difference we can make. And, you know, what was interesting, after the first change day in 2013, we commissioned a learning review. And what was interesting about what came out of that learning review was the number one piece of feedback from our frontline colleagues was, you know, I don't feel I've got permission to make change, okay? That, you know, I don't feel that I can work in my existing environment and make changes happen because I just haven't got the permission to do it. And you know what's interesting is when we've done the formal evaluation since of NHS Change Day, okay, the number one piece of feedback that we've got about Change Day is that actually, in a sense, the biggest impact of it is it gives our frontline colleagues a sense of authority. You know, it gives them a permission to make change happen. So, it's taken us 3 years, but you know, the level of engagement and impact that we get from Change Day is really amazing. So in 2014, there were 800,000 pledges to take action, and I just put a few of them here. So a lot of them are about our clinical colleagues like stepping into the shoes of patients and families. So here we've got a paediatrician who's on a bodyboard and only actually stayed on the bodyboard for an hour. And we've got a GP who was in a wheelchair for a day. I don't know if you can see this one right down in the bottom right-hand corner. You know, this is the consultant radiologist, Vikas. And what he did, he said, I pledge to undergo the same preparation that my patients do for CT colonography so that I have a better understanding of how it feels. And, you know, he had been a consultant for 15 years, and it's the first time he'd ever stepped in the shoes of his patients in that way. And then we've got one of our patient activists near the top there who is working towards making Leeds a dementia-friendly city. And if you can see the green group here, this is the leadership of one of our hospital systems, and every single leader made a pledge to make a difference and you know, really help the rest of the organisation. So you know, it's amazing, you know, and like nobody gives us permission. A few people give us money, which is good because we need it. 98% of the activity is carried out by volunteers. You know, it's that sense of igniting. I'll show you one of my favourite ones. Anybody know what this is? Okay, this is called the lithotomy challenge. And basically, a group of women who you know, mothers who use maternity services, they challenged their, you know, the doctors across the country to get into the stirrups that women use, and to wear them, not to wear them, to lie in them for an hour, okay? So our obstetricians across the whole of England, okay, took the lithotomy challenge. And this is Jim Thornton. He's a professor of obstetrics at Nottingham University, and he's 6'7" tall. And this is what he tweeted out, you know, the lithotomy challenge, not happy as I look undignified and disempowered, you know. So it's great, you know. So Change Day is a day of doing things you'd never do that would make a difference or give you a different perspective. So yeah, Change Day ignites me. It ignites my energy for change. And I don't know. I just kind of, because some people like data, so I put some data in here. So you can see this is what we do called social listening, because you can't evaluate something like Change Day with normal kind of evaluative techniques. So we did this process called social listening. And what that's about is looking across the whole kind of range of web activity, not just social media, but mentions on the web. And you can see 2014. In 2015, we had 6 times the activity that we had in 2014. You know, we get people to pledge, but very often people aren't actually formally pledging on the website, but they're still doing things. And what we found was that 2/3 of all the hospitals and provider organisations in the NHS had changed their activity. It was really amazing. What's also interesting there is that you get a big volume on Change Day itself, on the actual day, and then there's like a wall. It almost stops. And that's almost the nature of doing things on a particular day. But what's interesting is we set up a whole set of different campaigns. We have campaigns around people living with dementia. We had campaigns, and this one here is around maternity experience. We had campaigns around mental health. And what you can see from this is that even though Change Day is just one day of the year, it's like a catalyst of energy for all sorts of campaigns around our system. So, yeah, that's what ignites me. So what I thought we'd do is a little bit of, you know, just kind of warming up for our summit on igniting change. So think about a situation that you've been in, you know, when you think, like, you know, what you've put on your badge that you're ignited by. Okay, have a think about a situation where you felt really energized for change, where all on that, you know, that particular point, everything came together, when your efforts at change kind of surged with energy and you were part of an unstoppable force for positive change. And obviously it might not be something as big as NHS Change Day with 800,000 pledges, but, you know, it's something that's meaningful to you. So just say hello to the person next to you and talk about when you were ignited for change. Okay, just give you a couple of minutes. I'm going to move us on, if that's okay. I'm going to move us on. Okay, what's great, what's great is just how much energy there is in this room. You know, I think we're really building a really great foundation for a quality summit that's about igniting energy for change. Now, in the world that I live in, where people are thinking about large-scale change and transformation, this figure here, 70%, has almost a mythical, quality. It's it's like people talk about this figure all the time. Why do people talk about this figure, 70%, in the context of large-scale change and transformation? Does anyone want to shout out? Go for no tipping point. They're good answers. They weren't quite what I was looking for. Anybody else want to have a go? Okay, I'll tell you. Okay. So, it's the sort of the mythology is that 70% of change initiatives fail to achieve their objectives. Okay. So, it's interesting. So John Kotter was writing in the Harvard Business Review 20 years ago. And basically, he was saying 70% of change efforts, fail to achieve their objectives. More recently, the Gallup organization has done a big study around the world globally, and they've come to the same conclusion. About 70% of change initiatives fail to achieve their objectives. Why is it? We're 20 years on, and we're still, finding the same kind of statistics. So actually, I want to talk about energy as a way of overcoming this, and in a sense, using energy to think about how we can make our change efforts more effective. So I'm going to show you some data now, and this comes from McKinsey, so it's got to be right. So this was a study that McKinsey did with 3,000 leaders of big organizations, like across the world. So this was public, private, not-for-profit. And what was interesting is that whatever sector they looked at, the results were quite similar. And what they found was that only about 25% of change efforts get anywhere near achieving and sustaining their objectives. And the reality is, it's probably nearer 5% where we set some really big radical change goals and we actually achieved them and we moved on to the next phase. So I guess, for us here in Alberta today, the kind of big question is, what do we need to do to increase our chances and make sure that we're at least in the 25% and ideally in that special green 5%? So I actually think focusing on energy is very helpful. Because if you look again at some of the evidence base on what happens around large-scale change efforts, what it tells us is the thing that is least likely to happen is the thing we want to happen, which is number 3 on this list, which is we undertake this change, it becomes reasonably well established, because it's large-scale complex change, several layers across the system, things change, and we're able to accommodate it or sustain it, on an ongoing basis. So the third, or the least most likely the least likely thing to happen is the thing we most want to happen. And the most likely thing that is going to happen with our big change efforts is that they run out of energy, they fizzle out, and they fade away. So how do we create energy for change? Not just in this initial phase when we're very enthusiastic, but how do we create energy for change for the long haul? You see, I think this quote here from Tara Pollock is very true. Typically, around any change effort, there is an initial spike of very tangible energy. But often what happens is that leaders lose interest because other things come along, there are new priorities. So what happens is that the momentum of the change slows down drastically. And again, we see that time and time again, the role of energy in large-scale change. Who's been part of a change effort where that's happened? Yeah, me too, a few. So I think when we're talking about change, I think it's very helpful to contrast an anatomical approach to a physiological approach to change. So let's look at these. So when we're taking an anatomical approach to change, what we focus on is like the shape and the structure of the system. and how we might change it to deliver our goals, and how we might redesign the structures, redesign the processes of care to give us the healthcare outcomes that we want. So when we're thinking anatomically and we're undertaking anatomical practice of change, it's about, how can we fundamentally redesign our clinical systems? How can we reduce harm, reduce risk, unwarranted variation, waste, and so on? How do we redesign our pathways of care so that patients get a better outcome? How do we standardize what we do? And it's about measuring and metrics and outcomes, okay? Anatomical change is really important and we need to be doing it, but it isn't enough. Okay, we also need to think about the physiological approaches to change. And when you think about physiology, like the lifeblood, the vitality and life-giving forces that enable our systems and the people who provide care to develop and grow and change. So when we're thinking physiologically, we're thinking in quite different ways. It's about how can we create a higher purpose and deeper meaning around the change so everybody understands why we're doing it. How can we lead through values? Because actually the evidence is really clear. If we want people to engage in change, to be mobilized for change, the most effective way of doing that is through emotions and values. Okay? How do we build commitment to a different future? How do we create hope and optimism about the future? And how do we call people to action? Now, what I see time and time again in healthcare systems around the world is we absolutely need both for our improvement efforts. But very often we over-focus on the anatomical and we under-focus on the physiological. And when we go to improvement school, we learn quality improvement methods. Time and time again we learn the anatomical, but we don't learn the physiological. And I'd say that very often when change processes go wrong or we don't achieve our objectives, it's very often because of the physiological aspects and not because of the anatomical ones. And these physiological ones are all about energy, how we build this collective energy. And Peter asked, how do we build, have we got a collective will for change in Alberta? I'd also say, or I'd add to that, have we got a collective energy? Okay. So, let's look at some of the realities of this. Again, this is from, I'm having a bit of a McKinsey day today because this is a quote from McKinsey's research as well. What these McKinsey researchers found is that what leaders care about, when we're putting a message out to our workforce about change, about 80% of what we're saying and the messaging that we're putting across about change, okay, doesn't connect with the motivations of our workforce, about 80% of the motivations. So often, when we talk about waste in healthcare, actually, I think this is one of the biggest sources of waste. In a sense that we're putting all these messages across and we're putting them across in ways that just aren't connecting with the energy, the necessary energy of our workforce for change. Ron Vaal, he's from the Netherlands, and he says, we're always saying to our staff, you need to be ready for change. Big change is coming. We need to change. But what we don't engage in is sense-making. We're not making sense of it for people. And the thing about sense-making, it's not about marketing or getting the slogan right or communicating 6 times. Actually, sense-making is about making an emotional connection with our employees. Let's look at the evidence. What is the most effective way of mobilizing and engaging people for change? It's about connecting with emotions and values. And in fact, when you think this way, it helps us to think differently about this idea of resistance to change. So often, like the change programs I get engaged in, there's a group of people that are like the resistors, and we put horrible labels on them, like in denial or laggard. But maybe what we need to think about is why are people resisting? And actually, maybe that resistance, so-called resistance, is because actually we're not sense-making about the change. It's that resistant behaviour is an indicator of the relevance of the change to that individual. We haven't made sense, We haven't connected with energy. Now, I know that you work with Gallup here in Alberta around staff engagement. So I thought I'd put this in because I think it's quite interesting. So Gallup, who do really cool stuff around staff engagement, they did this big study all across the world. They did it last year. And what they looked at was, how engaged is our workforce? And these are, I mean, there's more of them, but I just kind of brought these out here to make a point. You know, they talk about, or coming out of this research, two kinds of people at work. And one kind are called compliant and the other kind are called contributors. So let's look at the compliant people, okay? Compliant people typically feel disconnected from the purpose of the organisation because, you know, like nobody's making sense of it for us. So we're doing these change initiatives and we're like being pushed to do this change, but it's not making sense. So our work is controlled and coordinated by performance management mechanisms and standardized procedure. You know, this is the clinical guidance you have to follow, okay? This is the quality standard you have to follow. So often, when people are working in a way, you know, where they're compliant, they kind of like, they hold back. You know, they don't necessarily give their best. And often they'll resist change because this is the standard, this is the procedure, we've got to stick with this. And very often, you know, they'll work to a role specification. And I come across this in my work so often. So it's like, you know, we talk to a particular clinical colleague and say, we're going to have a test of change. We're going to do this. We're going to try and deliver care to this patient in a different way. Just a small test. Or no, can't do that. Can't do that. It's too risky. It's outside of my job description, you know. Let's compare that with people that are contributors. You know, people that are contributors are working in environments where you know, leaders are making sense to people. So people that are contributors feel really connected to the higher purpose of the team or the organisation. And actually, they're really easy to control and coordinate because there's such a strong sense of shared goals and shared values. And you know, these people are collaborating all the time in their own team, in other teams. They're embracing change, you know, bring it on, I want to be part of it. And they work not to a role specification, but who they are. You know, the reason why I'm a nurse, the reason why I'm a doctor, the reason why I'm a physiotherapist, why I choose to do the things I did. You know, the work I do every day, I feel a profound sense of connection of who I am in the world. I think that very often healthcare organisations want people to be compliant. You know, if you listen to people like Don Berwick from the Institute for Healthcare Improvement in the USA, he says every system is perfectly designed to get the results it gets. And I think too often in healthcare, we work in systems that want people to be compliant, to do the job, to not question, to not challenge the status quo. And what's sad about that is if you look at that Gallup research, what it shows is that only, you know, worldwide, only 13% of the workforce are contributors or the kind of people that are fully engaged. And yet, these contributors create 6 times the value to an organisation compared to compliant people. Okay? So how can we build contributors? Right, what I'm going to do, I'm just going to stop there. Just going to give you 2 minutes. Have a chat on your table about compliance versus contributors. And, you know, where are you? Okay? And what do we need to do about this? So literally 2 minutes. I'm going to move us on, if that's okay. Going to move us on. So, hi, going to move us on. It's really fantastic that the conversations are like they are. Okay, going to bring us all back together. So, wouldn't it be amazing if one of the goals that came out today from our Quality Summit on Igniting Change was that everybody said, you know, I'm going to burst out of my kind of compliance suit and I'm going to be a contributor, okay? And, you know, just think about, when you think about the nearly 400 people in this room, you know, what a difference we could make. You see, you know, this ties in with these issues about intrinsic and extrinsic motivation, you know, and intrinsic motivation, you know, people are engaging in the change and the activity because it fits with our values and our goals, versus extrinsic motivation, where people engage because, like, we're nudged, you know, we're prodded to go in a certain direction. So let me show you an interesting example of this. You know, these extrinsic drivers, you know, this the way that we put kind of levers and drivers into the system to get us to perform in certain ways are very, very powerful. And this was an article that appeared in the Economist in London. And it was research that showed that charities, okay, 50% of them measure their impact to please their funders, and only 5% are measuring to improve services, you know. So it just goes to show, you know, we should be measuring because we want to improve all the time. You know, measurement's at the heart of what we do as improvers. This was a study, very, very interesting, that was published earlier this year by the Health Foundation, which is a fantastic charitable foundation based in England. And it was called Constructive Comfort, Accelerating Change in the NHS. And what they did was they looked at the 3 types of change that, you know, are used for large-scale change. And type 1, they call the prods, okay, the prod mechanisms. This is things like performance targets, you know, performance management, you know, payment for quality, payment by results, price and payment incentives, regulation, and in our system, you know, competition. So it's the kind of incentives and the drivers that we put in the system, the performance standards and goals that, in a sense, prod us to go in a certain direction. Type 2, they call proactive support. And this is what we do as leaders to really connect with that intrinsic motivation, you know, our values and the things that we hold dear that make us want to change. And type 3, they call people-focused. And people-focused is the things that we do with individuals. So it's about education and training. Again, in our NHS context, it's about national contracts. So we have contract for GPs, contract for hospital doctors. It's about professional regulation. It's about clinical quality. It's the things that we do with individuals. Okay? Which one of these do you think that kind of governments and health systems use the most to try and make change happen? One. Yeah. And yet, if you actually look at a system level, only 10% of the potential for improvement at a system level can be delivered through type 1 change. So it absolutely has its place, you know, and an important role. But it only takes us so far. And I think, you know, we've really got to be building the energy. We've got to be using the type 2 and we've got to be using the type 3. So, I like this quote from Dan Rockwell. Persistent application of power and authority drains energy from those in its wake. And if all we keep doing is kind of top-down, type 1 prod change, we're not going to achieve the kind of the big goals and the aspirations that the Deputy Minister talked about this morning. So, again, let's go back to this energy issue. I always have to show some statistics for the people in the audience that like data, okay? When we think about energy, you know, there's a whole body of research that shows that organisations with high productive energy, high energy for change, will score better on virtually every aspect of performance. So in my little team, we've been working for about 2.5 years now on this issue around energy for change. And we've done a whole range of publications that you can just download from the net. When we talk about energy for change, we mean the capacity and drive of a team, an organisation or a system, whatever level to act and make the difference necessary to achieve its goals. So energy for change is a pretty important thing. And this is the model that we've built, and we've tested it now on over 3,000 data points. And what it basically says is, if we want energy for change, if we want the kind of energy that'll enable our system or our team or our organisation to move towards its goals, we need to have an abundance of 5 kinds of energy. Social energy, spiritual energy, psychological energy, physical energy, and intellectual energy. When we first developed this model, we called it the PISSI framework, but it didn't quite sit. So now we call it SSPPI. So what I want to do now is I just want to just take you through the basic components of it. Okay, let's start with social energy. Social energy is the kind of energy where people feel engaged with other people. They feel part of a kind of a bigger collective. It's about partnerships. It's about relationships. It's about connections, where people are feeling, really well connected, very socially supported. There's strong social energy. And it's when people feel a sense of, us and us rather than us and them. The next kind of energy is spiritual energy. And this is about the energy that is about it's not religious in any way, but it's about, like a commitment to a different future that we all kind of understand, and that's, driven by values and a commitment to a shared purpose. And when you've got very strong spiritual energy in an organisation, it gives people the confidence to actually get involved in change and move forward to a different future. The third kind of energy is psychological energy. And this is the energy of feeling I can put my head above the parapet, It's about having the courage, the resilience, and feeling safe to innovate. And psychological energy, it's very much about the people around me and my own leaders, and the extent to which I trust them. I trust what they're doing. I trust the direction things are going in, that I actually feel safe to make changes happen. Okay. The fourth energy is physical energy. And physical energy is the energy of implementation, making it happen, getting things done, And then the final energy is intellectual energy. And this is the energy of, it's the rational energy, analysis, planning, thinking. It's about, getting insight. It's about, planning. It's about program management offices. It's about work streams, and it's about evaluation and arguing the case on the basis of logic or evidence. So if we do a little summary of the 5 energies. So social energy, okay, where social energy is low, I feel very isolated as an individual. But where social energy is high, I feel a real sense of solidarity in the people around me. When spiritual energy is low, I feel uncommitted to the organisation and its goals, and I just think, they might say stuff, but I don't really believe it, But when spiritual energy is high, there's a real sense of, commitment to a higher purpose. When psychological energy is low, I don't innovate, don't want to try doing things differently, don't want to test new things because it's too risky. But when psychological energy is high, I feel safe to innovate and do new things. Okay? When physical energy is low, there's a real sense of fatigue, tiredness, change fatigue. But when physical energy is high, there's a real sense of vitality around the team or the organisation. And finally, when intellectual energy is low, it's like, why on earth have we made that decision? That's like ridiculous, illogical. But when intellectual energy is high, there's a real sense of, reason, order, sensible decision making. Now, like I said, we've got more than 3,000 data points on this now. And when we work with healthcare systems across this globe, there's one of these 5 energies that we consistently see, okay? Particularly in leadership teams, that is more dominant than the other 4. Okay? Let's do a little vote. Let's see what you think it is. Okay? So if I was to say to you, which of those 5 do you think is over-dominant, is consistently over-dominant in leadership teams? Okay? Who thinks social energy is over-dominant? That's correct. Who thinks spiritual energy is over-dominant? Okay? A couple of people, but not many. Who thinks psychological energy? Okay, a few of you. Who thinks physical energy? Okay, more of you. And who thinks intellectual energy? Okay, you're right. Okay, there is, in healthcare systems, we see this over focus on intellectual energy. It's like, here's the work, here's the program plan, this is how we're going to achieve our cost and quality goals, here's the 11 work streams, here's the program management office, here's the accountability, and we're seeing that time and time again. What we also see in healthcare organisations is a very toxic mix of an over-focus on intellectual and physical, and actually physical was the second most common one that you said as an audience. And what happens when we get that? It's like, here's the program plan, here's the work streams, you're the accountable officer, right, you've got 6 months to deliver this, off you go now, boom. Okay, and often, when people are talking about change fatigue, when people are talking about burnout, it's that combination of physical and intellectual. So actually, most of the healthcare organisations that we work with, and it's a kind of shame to say it because of the very nature of what we do. In most of the organisations we work with, we are having to build social and spiritual energy. Okay. Here's another thing. Which group is more likely to have a higher spiritual energy score? Do clinicians tend to have a higher spiritual energy score, or do non-clinicians? What do you think? Clinicians. Yeah. Clinicians have a statistically significant higher spiritual energy score than non-clinicians. Okay. The nearer you are to the big boss in the organisation, do you have higher or lower energy scores overall? Yeah, higher. Okay. The higher you are in the hierarchy, the higher the energy score you tend to have. So one of the things that we do is we work with these profiles. Energy for change. And what we do is we help teams and organisations look at where their energy levels are at the moment. So what you can see there, can you see there's the 5 different dimensions of energy? And what we do is we'll score. So if you've got a score of 1 or 2, it means that your energy level on that particular domain is low. But if you've got a score of 4 or 5, your energy domain is high. And then the kind of questions that we look at when we coach around this, are particular energy domains more dominant than others at the moment? And what energy profile would we like? So I'm going to show you a couple, and I'll let you have a little chat as a team. Okay, we'll see what you think. Okay, so this is number 1. Okay, have a chat on your table. Okay, what's your sense of the energy profile of that organisation or that team? Okay, I'm going to bring us back, if that's okay. This is a profile from the leaders of a major university teaching hospital. And we see this kind of profile quite often. So, what you've got here is very high intellectual and very high physical energy around, the whole way that we go about planning and making change happen in a very logical, rational way, and get people in taking a lot of activity. What's interesting here is the relationship between psychological energy and the other energies. Because what happens is typically when social energy and spiritual energy are low, then psychological energy will be low as well. Because basically I don't feel a sense of, connectivity and partnership, and I don't feel a sense that we're moving towards a bigger purpose. So it doesn't feel a good environment, for taking risks. Teams find it really helpful to do this kind of profiling because what it does, more than anything else, it gives us the opportunity to have a different kind of discussion, because we can see that for what it is. So what we do with this team is to basically say, what are the actions that we can take or, that you can take to really build your spiritual energy, to build a sense of future that we're all moving towards. What does that future look like? How can we frame that future in a way that people really want to buy into it? And in terms of social energy, what can we do to build a much stronger sense of cohesion and collaboration and partnership? And it will make a big difference. You see, the problem with a profile like that, particularly where you see such strong intellectual energy, this is a team that has got transformational ambitions for their organisation. And the problem is that intellectual energy, where it's so dominant, isn't transformational. Because if it's like intellect to intellect, it just keeps us in our current comfort zone, And I think it's very, very difficult to build transformational change or build the right foundations for radical transformational change when you've got such a mismatch between social and spiritual and intellectual and physical. So, if this organisation wants to build a transformational strategy that takes in all the workforce and all of our partners, we need to really work hard at spiritual and social energy. Okay, let's have another look at another one. This one I'm going to show you now is a district nursing team, okay? Okay, we're coming back with this one. Okay, so let's look at this one. So this is a team, that have worked together for a very long time, and it's a very mature team. So their social energy is really high, in a sense that we trust each other, we work really well together, there's really strong collaboration in this team. And again, as a result, because the social energy is so high, the psychological energy is very high as well, because that social energy creates a space, where people feel very safe because everybody looks after each other's back. But intellectual energy is like really low, so there aren't proper processes for thinking about how could we change. There aren't really good kind of planning and implementation processes in place, and also that very strong dominance of social energy, okay, is filling a vacuum that's created by a lack of spiritual energy. So this team hasn't got a strong direction of where it's going and how it wants things to be for its patients in the future. But again, it's really easy and very positive to have a conversation with this team and talk about this and talk about how we can build that intellectual energy and the kind of processes and how we can, work on the back of all that fantastic social energy and build that spiritual energy as well. So this is all very helpful. So okay, 2 minutes. Where's your team? Where do you think? Okay, let's go back together. Okay, so only you can answer that question. But if you're like a lot of the teams we work with, okay, it's worth thinking particularly about how we build social and spiritual energy. You see, this is a quote from Mintzberg, and he says, "Leadership is not about making clever decisions and doing bigger deals. It's about helping release the positive energy that exists naturally within people, It's about igniting energy for change." And I think there's never been a time in the history of healthcare where this advice has been more pertinent. So what are some of the ways of thinking in terms of building social and spiritual energy? I think a really good place to start is thinking about shared purpose. And what we keep doing, because we're so dominant on intellectual and on physical energy, is we're so action orientated. It's like, oh, well, we're going to do this change program. We're going to redesign urgent and emergency care, and straight away we're like, designing the infrastructure and the program mechanics and the work streams. Okay, and all those things are important. Program management officers are really important. Okay, and they make a big difference, but not in a vacuum. So we need to really think about how we build shared purpose. And when you look at successful change programs, successful change interventions, what we see time and time again is this issue about building a shared purpose before we begin. And organisations and change initiatives with a strong shared purpose consistently outperform those without it. So, when we talk about this, I think it's very helpful to think about 3 words: our shared purpose, okay, and think about all 3 of them. And again, I think this is very helpful in terms of social and spiritual energy. So in the context of the social energy, who needs to be part of the hour, okay? So who defines the benefit we're trying to achieve? Who are the people who are going to make the change happen? Who's it going to affect? Because all those people need to be part of developing it. Then the second word is shared. And the thing is that, often we want a very diverse group of people to contribute, to this and to be part of the change. And there are so many things that differentiate us. There are so many ways in which we might be in conflict with each other, or we might be different. But what are the things that in the context of this change that we're trying to achieve, okay, really matter to us all? What are the things that unite us? And then finally, the purpose, okay? This is the heart of spiritual energy, This is the why, Why is it really important that we do this now, okay? Why is it urgent that we all play our part in this change, okay? And what I see time and time again, when it comes to energy for change, okay, we don't focus enough on purpose, and we don't sense make around it. So, when the McKinsey researchers are saying, 80% of the messages that leaders put across don't link with 80% of the motivation of our workforce to put effort and energy into the change program, very often it's because we're not clear about purpose, and not just defining purpose in a rational, logical, intellectual energy way, but defining purpose in a values and emotion-driven way that make people want to be part of it. And this is my favourite quote about shared purpose that I think really describes it, from Seth Carguilio. And he says, "Shared purpose goes way deeper than vision and mission. It goes right into your gut and taps some part of your primal self." And he says he believes, and I believe this too, if you can bring people with similar primal purposes together and get them all marching in the same direction, amazing things can be achieved. So in a sense, what we want to do is build on our fantastic strengths in intellectual energy and physical energy. But we want to put a massive effort at the beginning of the change process into building the spiritual and social energy to match them. And that's when I think the magic of change happens. Okay? And just one example, and this comes from a study that was done of a change initiative which was across England called Matching Michigan. And what happened was the state of Michigan in the USA did this fantastic quality improvement initiative around central line infections. And across the whole of the state of Michigan, they were able to get really excellent results around eradicating central line infections. So we had a National Patient Safety Agency in England, and they decided that we were going to match Michigan. England was going to match Michigan. And what was interesting about this was of the 11 intensive care units that took part in this, okay, only one matched Michigan. And it was interesting because there was a very interesting study that was done of this, you know. Perhaps the single most important influence on the response by individual units was the extent of consensus and coalition amongst the senior medical and nursing staff on the individual ICUs, okay? Classic social energy, okay? And the consultant says, I think it's been successful because it's a unifying program. It's been one of the few things that we've done that hasn't just been a doctor thing or a nurse thing. It's involved the doctors and the nurses together, okay? And also, you know, what the study showed was these, you know, where you had really strong clinical leaders, what they were able to do was to sense make. And you know, part of the reason why it didn't work very well in a lot of ICUs was because people didn't think it was a problem. They didn't think that, you know, that their unit had a problem with central line infections, okay? They didn't think it was a priority. And it was in those units where the clinical leaders were able to make the case, if you like, to work with and build the spiritual energy and build the social energy that it made a difference, okay? Last thing I want to talk about, de facto purpose. Okay? When I look at the issue of shared purpose around healthcare systems, I think this is one of our biggest problems. What happens is, as leaders, okay, we're sending messages out all the time about what's important, and the things that we choose to talk to about with our staff send very strong and powerful messages about what's most important, and it's what they end up paying attention to. And because we only talk to our staff or our teams about certain things, they think that those things become the purpose. And our big shared purpose, you know, with our that builds our spiritual energy, gets displaced by a de facto purpose, which is toxic. And it's all about, you know, we've got to hit the target, we've got to reduce costs, we've got to eliminate waste, we've got to complete activities within a timescale. You know, we've got to comply with a regulation or inspection regime. And if our bigger purpose isn't explicit and it isn't shared, then it's very easy for it to become a de facto purpose in the minds of the workforce. And having a de facto purpose is like foundations of sand for making change happen. Anyone know what that is? Okay, I'll tell you what it is. It's the purpose obfuscation-ometer. And this was designed by one of my Twitter friends, Simon Guilfoyle. And he is a police inspector, and he's also a genius system thinker. And what he basically talks about is how, like at one end of the machine, we put in, you know, the shared purpose with the spiritual and social energy, and what comes out the other end is the de facto service, de facto purpose. So let me just show you some examples. So he's a police officer, so let's look at a police one. So what goes in is that, you know, the shared purpose. The concerned citizen says, please find the person who burgled my house. And it goes through the machine, and what comes out the other end is we can only afford another 4.3 burglaries per day for the rest of the month, otherwise we'll miss the reduction target. Okay, education, this is English, so we have to translate. You know, the concerned parent, I want my child to learn and grow up to be a fantastic adult who contributes to society. Goes through the purpose obfuscation-ometer, what comes out the de facto purpose. Schools should be ranked in league tables according to the proportion of students who acquire the specified exam results. And of course, it never happens in healthcare. So, you know, this is the person that comes into the emergency room, you know, with a horrible injury on their arm, you know, really bad, and they're very frightened and in a lot of pain, and they say, please help me to get better. And again, it goes through the purpose obfuscation-ometer, and what comes out the other end. A 95th percentile of emergency patients must be admitted, discharged, or transferred within 4 hours of arrival in the department. And, you know, we can laugh at this, but it's what we're doing. You know, we're replacing our bigger shared purpose around our basic reason for doing the jobs that we're doing with a de facto purpose. And of course we need to have goals, you know, and of course we need to have, you know, quality standards. But in a sense, it's like, how do we make sense of those? And what I see time and time again in our system is the difference between those leaders that are able to sense make around those goals and link them with bigger purpose versus the leaders that just focus on the de facto purpose. So the last thing I wanted to say, really, just a nice little quote to end, you know. The last era of management was about how much performance we could extract from people. The next is all about how much humanity we can inspire. It's where we need to go. We need to build the energy. We need to build the spiritual and the social energy. And it's fantastic to be here with you today, igniting change in Alberta. Thank you.
Stay here.
Oh, wow. Get a bag.
Well, there are people who know things, people who've lived experiences, and people who can inspire. And the Venn diagram around those three has very few people that intersect. Helen is one of them. Please join me in thanking her for a wonderful, wonderful talk. Thank you. Of course you do. Okay.